Lunch and Learn with Dr. Barry. This is episode number 12.
Thanks for listening to the Lunch and Learn with Dr. Barry, here to help educate, motivate, and put you on the right path to take control of your health through weekly discussions on topics in the medical field, public health arena, and in your community. And now your host, Dr. Barry.
Welcome to the Lunch and Learn with Dr. Barry. Today we're going to be talking about depression, which is something that I deal with in my office quite often. We're going to be talking about some signs and symptoms of depression, what you should be looking out for, not only in yourself, but in family members and others. We're going to be talking about different treatment regimens that can assist with depression. Again, and we'll definitely get into counseling. You guys know how I like to talk about counseling. And if you would like some show notes, please go to drpierresblog.com/LLP012. Again, if you would like the show notes, please go to drpierresblog.com/LLP012. Get ready for another great episode. Today's topic, again, not somber, but today's topic is almost maybe as quick depressing in regards to depression in the primary care office, and more importantly, the lack of screening for depression, especially by primary care physicians. I just read an article yesterday. I think it's going to be in the American Journal of Psychiatry, I believe, or the Annals of Psychiatry, that talked about even though guidelines are saying, and all these these new rules and mandates are saying screen for depression. We're still not doing it. Hey, Maria, thank you for joining. Thank you for liking and sharing. Like always, when you join, go ahead and press that like button, press that share button. Let the whole world know of the Lunch and Learn. The article that is going to be published in Annals of Psychiatry and then talked about how the incidence of screening for depression in the primary care office is like abysmal. And when we talk about abysmal, the rates and first of all, let's give a little quick background, right? During your annual visit, your routine annual visit, one of the things that insurance companies are now paying for, and this is important, they're now paying for, is for you guys to get your a depression screening. And depression screening isn't 100 different questions, just a couple questions here and there. I usually ask about 5 or 6 questions. There are like standardized ones, but about 5 or 6 questions, just kind of seeing, the overall state. Hey, Jen, thank you for joining. Thank you for liking. Thank you for sharing. Appreciate that, my cousin Jen. We're talking about depression today. So again, some screening questions where they're pretty much now paying doctors to like say, hey, ask your patients, are they depressed, or could they be depressed, or could they be dealing with factors that could lead to depression. And the numbers are startling. I think the screening rate is only about 4%. So only 4% of times when you're actually going to the doctor's office is your primary care doctor even asking you, are you depressed, or asking you questions that could, lead to believe that you're depressed. And it's even worse when we talk about African Americans. I think that number was down to like 1 to 2%. So, we have this, and the flip caveat is that out of that 4%, almost 50% of the time when they ask, like, hey, are you having, trouble, issues with depression, sadness, guilt, anything in that kind of led them in that direction, almost 50% of the time they were actually correct. Like 50% of the time they actually diagnosed a person with depression. So the question is like, why isn't, the primary care doctors or your doctors in general? It doesn't have to, and I do state it because it doesn't really have to be a primary care doctor. It could be your cardiologist. It could be your OB. It could be any doctor you're seeing. Why aren't they asking for this? And I think the big thing is a lot of them, and I hate to say it, a lot of them, just really don't care. Like, if you don't, explicitly say, hey, I am depressed, they're not, that's not really in, the front of their mind to even ask. Again, a lot of times, when we go to see a doctor's office, we're seeing them for, whatever reason, back pain, headaches, I got a cold. And, a lot of times that isn't in the front of their memory to even think about it. But what was happening, even when you're going in for your routine annual physical and if you had the physical, check out, I think it was episode 2 or 3, when I talked about, what goes on during annual physical exam, it's just ain't coming out. Your question is that word, right? Exactly. They're not asking it. And let me tell you, and that's a very good point, Jen. And let me tell you, the majority of my patients, right, are not flat out telling me I'm depressed, right? In fact, majority of people are never going to say, hey, I'm depressed. They will usually have a lot other different issues. Hey, I'm having, trouble keeping up in school. I'm having trouble keeping up in work. I'm having some issues at home. I'm having issues falling asleep. They're almost never going to say flat out, I'm depressed, right? So that's why it's important, especially from a physician standpoint, that we really have to kind of see some of these signs and symptoms and see if there's something that we can kind of pull out, because unfortunately that word depression still is, and really the word depression for most of our mental health issues still is looked down upon, especially in the African American community, and I can speak on them. It's still looked down upon. It's still not respected. So a lot of us don't want to even be kind of quote unquote classified in that realm. So when you start asking, especially, when you start asking your patients like, hey, any issues with depression, any issues with anxiety, they're 9 times out of 10 going to tell you no, right? They're not going to, no, I'm not depressed, I'm not anxious. But when you start asking, questions like, well, are you having any trouble sleeping? Are you having trouble eating? Are you having trouble, really, coping with some of the stressful things that you've been dealing with? Nate, what's going on, Nate? Are you having any of these, issues that kind of relate to depression? A lot of times they say yes. So as a primary care physician, we really have to be very mindful, one, of how we're asking these questions, and 2, really, we just have to kind of listen. I had patients who, they come to me for, very vague complaints. It really doesn't really point to anything. But when I start asking them, well, how's family, how's, marriage, how's a relationship? When I start asking them all of these, outside the box questions, they tend to end up giving me, an answer that says, hey, yeah, well, I think you may be depressed. Like I got patients, especially, and let me tell you, we're going to talk, I like to talk to my men, especially when it comes to healthcare, because, they're supermen, right? A lot of times my men will be dealing, and men specifically, they deal with a lot of financial stress, right? Where financially they can't keep up. Medically, they're having problems. Family, they're having problems, right? And they can tell me like, hey, I'm having problems sleeping, I'm having problems eating, I'm having problems, just trying to, get through the day. But the second I say, well, do you feel depressed? No. I'm not depressed. Like, because again, that stigma, like Jen said, the stigma is so detrimental in our community, and not just our community, but specifically in our communities. The stigma of being depressed is so vilified, unfortunately, that it's very hard to even get to the next point where we're trying to treat it, right? So I can't even get to the point where I say, hey, you are depressed. And if I can't even get to that point, then how can I possibly treat you? Because the next step is like, oh, well, what do you do for treatment? Everyone, there's they feel like there's medications for everything, and is there medication for depression? Sure, but everything, all of our guidelines and everything says that these people need someone to talk to. Like, these people actually need some counseling. And then all of a sudden it showed that if they do counseling and they do some medication, because not to say that counseling is 100%, that we know they get a better outcome. But unfortunately, I can't even get them to the point where they even want to accept the diagnosis. So a lot of times it takes a couple of visits. Like, I got patients who, and those patients, when I see them, I'll make them come see me a lot more frequently. So I'm like, just come see me next month, so I can check out, see how your blood pressure is doing. Like, just very random, right? It has nothing to do with their blood pressure. I know they're depressed, and I know this is someone I need to really keep a little bit closer eye on. And again, just because I've seen the signs over and over again, so I know this is a person I really need to watch, and I'll do that. So I'll have them see me a little bit more frequently, because maybe they don't want to tell me in the first instance, right? that, they're depressed, but maybe after like the third, fourth visit, they'll be like, yeah, doc, you know what? Like, I think you're right, doc. Like, I think I may be depressed. Yes, exactly. Getting to see a therapist is extremely hard. Let's talk about from a financial standpoint, right? Because a lot of people, for some reason, think that these therapists are like terribly expensive, right? I'm in Palm Beach County. If you Google Mental Health Association of Palm Beach County, there's about 20 to 30 organizations that give counseling for free, right? 20 to 30 organizations, and that's just for the adults. If you got children who have issues, they got organizations for that. If you have elderly patients who have mental issues, they got organizations for that. So, so we have to, as a primary care physician, make sure that we eliminate that cost excuse, right? Because are there expensive therapists? Sure. Those are, the private paid therapists, they see, and again, some people like the private pay, so they'll pay for that. And I fully believe for a lot of people, cost is usually an excuse. A lot of people can afford, to pay a therapist, 60, 80, $100 an hour. They just rather not, because again, they don't want to have that stigma of being diagnosed with it. And then you have a lot of patients who, honestly can't afford it. I deal with a lot of patients who are on like the Affordable Care Act plans, who have lower incomes, and they really can't afford to see, a person for 60, 80, $100 an hour, right? But right when I tell them, hey, you got, free options out there, all of a sudden they got excuses for the free options too. So, we can't let people off, the hook when we talk about cost when it comes to therapy, because we know, like I said, if you stay in wherever county you stay in, if you do Mental Health Association of blank, blank, blank county, you're going to find organizations that can offer those services for a much lower discounted rate, if not for free. Okay, so very, very good. So Nate asked you, how common is depression among people who are introverts, and I think that's a very common stigma for people who are introverted, that they feel like, well, if they're introverted, they already don't like really being very social aspect, so they already have a higher risk of being depressed. And what tends to happen, that's usually not the case. There hasn't been anything that's shown that introverts are much more depressed than extroverts. It's just that especially for people who are extroverts, we're so used to those people being alone, and we just feel like, oh, well, something's got to be wrong with them. They never want to be around nobody. But most of your introverts, really enjoy being alone. It's like something that they kind of look forward to, and putting them in that state where they're around a whole bunch of people is actually a little bit more detrimental from a mental aspect of it. So there really isn't any a bias as far as who's going to be more depressed, whether they're outgoing, or whether they're just one that's just kind of like socially reclusive from that aspect there. But what tends to happen again, like life happens to everybody, so, financial issues happen to everybody. Relationship issues happen to everybody. And we're not even talking about, boyfriend, girlfriend, husband, wife. We're talking about, brother, sister, mother, father, uncle. There's a lot of family dynamics that can play a part in a person being depressed. We know that the studies have showed that, if you have a family member who's depressed, and you kind of grow up watching them in their depressed states, you have a higher likelihood of being depressed as well, because you just kind of you kind of simulate some of their same common characteristics in that regards. And again, not to say that because someone in your family is depressed, you'll automatically be it, but you do have an increased chance to be in it. And I think the big part, and I think physicians, we have I think we carry such a big burden, because a patient is more likely, and like Maria said, a patient is more likely to see me for whatever. They're going to likely interact with me before they interact with the mental health therapist, right? They're more likely to interact with their OB, their chiropractor, their dentist. They're likely to interact with those professionals before they interact with the mental health therapist. Why? Because again, especially in our country really does not like mental health. Unfortunately, and that profession is not something that they like, dealing with. So because they have that, and that stigma, like Jen said, that stigma is there, and so they're not even messing with it. So they rather say, I'm not even going to deal with it. I'm just going to kind of, accept it on my own. I'm going to kind of, quote unquote, deal with my own problems. And a lot of us have to understand that a lot of us can't really deal with our own problems. If we could, it'd be great, but a lot of us really can't deal with the constant stress of, what school may be doing to you, the constant stress of what your job may be doing to you, the constant stress of what your mom, your father, your boyfriend, your husband, your wife. A lot of us really can't deal with that on a consistent basis. And sometimes when we send patients to, because I refer a lot to the therapist as well, and the big thing for them is they just need someone to talk to. Like, they come to see me, they can see me, 15, 20 minutes, even 30 minutes. Sometimes I got some patients who, I'll block 30 minutes because I'm usually seeing for mental health reasons. I'll block for 30 minutes just so they can kind of vent, because a lot of people don't even have that second person that they can just kind of, tell all their issues. Sometimes they may not even want the answer at that appointment. They just maybe just want to be able to, take that burden off themselves and just kind of let it out into the universe. So that's important, and I think that's what your primary care physician, especially any physician, should be here for. But then it's just knowing, when do I, go to the next level. Yes, they have to acknowledge that they're depressed, right? Because and it's such a big thing, right? Because again, if I have a cold, right, I got no problem telling a person I got a cold. I got no problem telling my back hurts. No problem telling, I broke my arm, right? I got no problem visualizing that, right? Because a lot of that's something I can kind of visualize. I can kind of visualize that. But when you hear depression, pronounces itself in so many different ways that there's not a one-stop shop, right, for it to say oh yeah, that person's depressed. There's no one thing that I can point to say, okay, I definitely know that the person is depressed because of this. There's a lot of signs and symptoms. Again, we talked about trouble sleeping, but then I have people who sleep too long. We talk about trouble eating. But then I got people who eat too much. We talked about trouble at work, where there's concentration. Then I got people who don't even work because they're so depressed they don't even want to deal with anybody in that atmosphere. So there's such a wide range of symptoms, signs and symptoms when we're dealing with depression that we really have to, especially again I hurt when I saw that article. Right, 4% of physicians are even screening for the depression, right? And it's crazy because now we get paid for it, right? So we can't even blame, they're not even paying for it anymore. We can't even blame that no more, right? We're actually getting paid. It's like a little code I can add on to the end of my note. We're getting paid for it, and we're still not doing it, right? And then I'm doubly hurt because out of the 4%, it's even less than that when we talk about African Americans, right? So again, and those, I don't know, I'm not sure where you're watching from. If you're watching from outside the country, if you're watching from the United States, right, African Americans deal with a lot, right? A lot of stress on a consistent basis over and over and over again, right? So, if anybody should be asking, hey, are you depressed? You should be asking your African American patients, right? If you're going to ask, if you say, I'm just going to ask, one race, you're not going to, but let's say I'm going to ask one race in my group, are they depressed? Please let it be the African Americans, right? We got so much stuff going on right now that it's crazy that we're not at least asking them, right? Let me see. Person relating to weight gain. Oh yes, definitely a lot of weight gain, especially because what happens when you're depressed. When you're depressed and you eat, eating actually triggers hormones that make you feel better. Right. So, and you hear a lot of people talk about I binge eat because there's hormones that actually get released while we're eating. In fact, if you think about it, just if you're hungry, you haven't eaten, all day, right, and you're about to go eat, just the fact that you're about to go eat, you start feeling better, right? And then what happens, right? Exactly, right? So then you eat to feel better. You feel better while you're eating, but then you're gaining weight. So then you start feeling sad because you gained weight, right? So then you have this repetitive cycle that and it happens all the time. Happens all the time, right? This repetitive cycle that you really can't even get out of, right? You're depressed for, all of these reasons on this side over here. You eat to feel better about the depression for all these sides over here. But now when we're moving forward, now I've gained 10, 15 pounds to try to deal with all of the depression issues over there. So it's definitely a cycle that repeats itself constantly. And again, and that's the thing too. Like if I see one of my patients, gaining weight, I ask, that's another my sign. Like I got a few signs that if I start seeing something that's different, if I see something that's different in my office, I'll ask them, like, hey, is everything all right at home? And that's how I do it too. Like I never use the word depression. I never use the word anxiety. I never use I never use those buzzwords, right? Because patients are aware of those buzzwords. I go all around it. Like I ask very vague. To them it seems vague. I know exactly what I'm asking, but like to them it seems extremely vague why I'm asking it. But like my goal, is to eventually say like, okay, all right, that's why you do. Like, well, I think, I think you're depressed. Like, I think, and again, and a lot of times I've had patients where like I've gotten to that point, like I've confirmed it. They've answered all of the questions. They've bubbled all the right answers. I tell them they're depressed. They say, no, they're not depressed. I'm like, all right, no problem. Let's see you in 2 weeks for, check your blood pressure. And then I bring it up again. And then let's see you in a month for that blood pressure. Then I bring it up again, right? Because just like my cigarette smokers, as long as you feel comfortable, once you start feeling comfortable with your physician, and you see every time you go to your physician, he keeps telling you like, hey, I think you're depressed. I think you're depressed. I think you're depressed. Eventually, it's like, you know what? I think you're right. And then I'm ready to get some help, right? Because again, it's a huge step to get to that point. It's a huge step to accept it, right? Because I can say you're depressed a million times, right? But until you physically until you like internalize that, yes, I am depressed, we can't move forward. But again, I mean, and I'll put out a link to that journal article. I don't think it's posted yet, but I'll print out a link when it gets to it. We know that if for at least 50% of the time, as long as I'm doing that, I'm gonna find a person who's depressed, right? But the problem is we're not even doing it that enough, right? If 50% of the time, like if I told you had a 50% chance to win the lottery, right? And all you had to do was play, what you're going to do, you're going to keep winning the lottery, right? Physicians, primary care physicians especially, we have almost a 50% chance to diagnose a person who may be depressed, who may not have told us that they're depressed, but for some reason we're not doing it. And right now, I'm not even sure why. Like I said, you get paid for it. So no, I mean, and the pay, let's say, pay may be like, I don't even know. Let's say $20, $50, but let's say $20 or $50. You get paid $20, $50, and literally you just gotta ask. Like it's almost like five. I think it's like, let me see. I feel like it's like 5 to like 9 questions. It's not that many questions, right? And they're not even doing that, right? So again, I think you have to be very mindful. Like when you got that physician who's doing for your annual visit, and a depression screen isn't one of them. You got to ask why. I think that's really the crux of today's Lunch and Learn is really one kind of identifying that a lot more people are depressed than what we even really want. So the crux is a lot more people are identifying. One is identifying that depression is real. It is. 2, identifying symptoms that may be present in your patient. Like I said, it's such a wide range. It's a person who eats too much. It's a person not eating enough. You see a lot of weight gain. You see a lot of weight loss. It's a person that's coming to your appointments for very vague reasons, but you're not really seeing anything like out the ordinary. It's a person who's having trouble sleeping. It's a person who's sleeping a lot. Like it's such a wide range that you just have to be very mindful and just keep an open mind. And then when we talk about treatment, we know the guidelines said, we know the numbers show it, that the combination of therapy and medication works much better than just medication alone, right? Because people will quickly take a medication, right? But if you're not talking out those problems, if you're not trying to get to the bottom of why you're depressed, and again, if you haven't been through a therapy session, you should. I'm very fortunate. My wife's a therapist, right? So I have to go to these therapy sessions like every day. I feel like every day I'm going, and every day and I'll peek because she'll be asking me very like weird. She'll be asking me questions. I'm like, hold on, is this a therapy session? Like, relax, right? So I go to therapy sessions a little bit more frequently than I need to. But what happens is, it's the thing that most people truly don't know. Yeah, they don't know. They don't know. But again, as a physician, right? So exactly. Most people don't know what depression is, right? They just think it's this person who's, on the couch and who's, just somber, who's sad, who's not really doing nothing, right? And they don't really know there's so many different caveats to what a person could be depressed and what depression looks like in someone that, that's why it takes the professional, I hope, it takes a professional to say, yeah, you know what? Yeah, I hear what you're saying. And I hear you thinking you're not depressed, but yeah, everything you tell me means is screaming depression, right? So, I think that's where we got to get to, right? The professionals really have to take a much more concerted effort in pulling out our depression symptoms and from everybody else, because that's really the goal, right? And we can't allow the excuses no more, right? No more excuses in 2017, right? No more. I can't afford help. We know that's a lie, especially if you're in Palm Beach County. Mental Health Association, Palm Beach County. Google it. A whole bunch of programs there. Google it in your county. I'm pretty sure there's a whole bunch of programs there as well. We just can't allow it no more. We can't, because we know it can be detrimental. Because again, if you're depressed, you're going to have trouble controlling that blood pressure. If you're depressed, you're going to have trouble controlling your weight loss or weight gain. You're going to have trouble sleeping. You're going to have trouble staying awake. You're going to have you waking up. You're going to have trouble with all of these things here. And then the end all be all, if you're depressed, long-term depression, we know that you're around children. We know that your children can pick up some of those signs and symptoms as well. So now your children can start presenting with, clinical aspects that could be of depression as well too. So this isn't something that is, that only affects you, right? Hey, Nisha, thank you for joining. My sister-in-law joining. We talked about depression today. Went through a lot of great part. A lot of shout out from my social workers and my mental health therapists. Y'all know I love y'all. We talked about it. So again, we can't, no more excuses in 2017, right? Depression is just not only affects you, it affects everyone around you. And when I talk to my physicians, when I talk to my physician colleagues, we have to do a much better job at even asking the questions. A lot of us aren't asking the questions, and I don't even know why no more, right? It's like I said before in hand, they didn't get paid for doing it, right? But now they get paid for doing it. So there's no more excuses, right? You getting paid to ask if your patient is depressed, go ahead and ask them. Don't ask it directly, because they're always going to say no. But ask them in a way where you can try to get to the bottom of it and get them some help.
Thank you for listening to this episode of the Lunch and Learn with Dr. Barry. If you want to find out more about the episode, please go to www.lunchlearnpod.com. That's www.lunchlearnpod.com for the show notes and any links that may have been mentioned in today's episode. If you're interested in joining the Lunch Learn Pod community, head over to either the website lunchlearnpod.com or join us on Facebook and Twitter with the same username, Lunch Learn Pod. And again, you can find all of these links on the website. If you have any questions, any comments, or any requests for topics to debut on the show, please let that be known. And don't forget to use the hashtag LunchLearnPod when you're listening to the episode. Again, I want to thank you for taking the time to listen to today's episode, and I'll see you next week.